Continuing mobile education for emergency medical services providers. This is Evaluating the Older Adult, Episode 2, Evaluating the Stroke in the Pre-Hospital Setting. At the end of this episode, participants should learn the components of a focused physical exam to evaluate stroke, be able to describe key physical findings associated with the stroke, and determine what information needs to be relayed from the scene to facility.
Some of the ways to evaluate a patient for stroke. Initially, you definitely want to fall back on your basics, the ABCs, airway, breathing, and circulation, checking the vital signs. And if it's not obvious at first, you want to definitely check for things like asking the patient, the family member, staff members at the facility where the patient is about weakness, numbness, tingling, any changes in their mental status, things along those lines. Once you've assessed and feel that there's a possibility for a stroke, one of the more common ways for a pre-hospital provider to assess a patient is the Cincinnati Stroke Scale. This has got 3 components to it. They involve facial droop, weakness, and problems with speech. The initial way to evaluate for facial droop is asking the patient to smile. If you see one side of the face moving less than the other, that would be a positive finding. You would also want to check for weakness by having the patient hold their arms up with their eyes closed, like this, and have them close their eyes for about 10 seconds. If there's a drop of one arm or if the patient's unable to raise it against gravity, that would also be a positive finding. And the last one is asking the patient to say, no, you can't teach an old dog new tricks. And if the patient has any problems saying those words, finding the words, or just isn't able to speak at all, that would be a positive finding as well.
The Cincinnati Stroke Scale evaluates 3 points, beginning with facial droop by asking the patient to show their teeth or smile. The second point is arm drift. This is evaluated by asking the patient to close their eyes and extend their arms for 10 seconds. The third portion of the Cincinnati Stroke Scale is speech by having the patient repeat a phrase such as "you cannot teach an old dog new tricks." Score only the first attempt.
As our EMS staff is very good at doing, I think monitoring the ABCs is very critical in a stroke patient, especially with large strokes that affect people's level of consciousness. Protecting the airway or aspiration in patients who aren't protecting the airway is a major complication that we often see either right after or in the days right after a stroke. So I think very close monitoring of an airway is very helpful for us. Stroke and myocardial infarction or coronary artery disease often coexist, and so we often also see patients who are having coexistent strokes and heart attacks. So monitoring of the heart rhythm, and EKG, pulse and blood pressure changes are very helpful for us, and that's also, especially high blood pressure, is something that's important for us in deciding if and when we can give IV thrombolytic therapy. So monitoring of the blood pressure is very important. Well, there are a number of different ways that a patient with a suspected stroke can be evaluated. I think some of the cardinal features that we ask patients to look for are also some things that we would ask our emergency medical staff to also look for. The major things we would be looking for would be weakness of half the body or of one limb, weakness of part of the face, sensory differences of one half or part of the body, visual changes such as losing part of vision or double vision, abnormalities in speech or language, or sudden change in level of consciousness. Those would be the cardinal features I would look at.
Other key findings found with stroke. Other key physical findings found with stroke patients also include facial droops and discoordination, either with movements of their arms or legs, or problems with walking. Can sometimes be the first things that are recognized.
Stroke physical findings include weakness or sensory changes in one limb, half the body, or part of the face, abnormalities in speech, language, or vision, and sudden change in levels of consciousness.
The three biggest sources of confusion that I think of when assessing a stroke patient are, number one, their blood sugar, because it could be low. It could be a case of neuroglycopenia, which presents just like a stroke. Another is previous deficits prior deficits from strokes or traumatic brain injuries or other things like that that have caused deficits that always exist. Another big one is eye surgeries, which affect how their pupils react. Perhaps that right pupil's never reactive or is never reactive.
Well, this is certainly tricky. This is what we really have to do quickly in an emergency department, is try to triage people in terms of whether they are or aren't having a stroke. I would say in an older population, either hypo or hyperglycemia are conditions that can mimic a stroke, particularly in people who may have had a stroke previously. Sometimes their symptoms can come back more or less in the setting of very high or very low glucose. Similarly, people who have an infection or other metabolic process can sometimes have reemergence of some of their stroke symptoms. Other pathologies or other disease processes we would consider would be seizures. Not all seizures involve convulsive activity, so sometimes patients can be having seizures and present as if they're having a stroke, or can have weakness or language problems following a seizure, what's called postictal or Todd's paralysis. In a younger population, another condition that we would consider would be migraine, which can present in an acute fashion and can sometimes present with focal features affecting part of the body or language.
Stroke mimics include hypoglycemia or hyperglycemia, infection, metabolic abnormality, seizures or postictal states, and migraine.
So the three of the things that we would hope that most EMS staff or emergency physicians would check for when examining a patient for stroke would be facial weakness, weakness of limbs, and speech or language dysfunction. In terms of examining the face, part of that is just observation and just seeing if at rest there appears to be drooping of part of the face. The nasolabial fold, which connects the nose down to the corner of the mouth, is often flattened on the side that's affected by a stroke, so that can be seen by simple observation. If a patient can participate in the examination, it's often helpful to ask them to smile or show you their teeth like this and see if there's any asymmetry or decreased movement of part of the face. Again, sometimes patients aren't able to follow commands or participate, so again, observation and seeing if they move their face when asked to talk or when stimulated in any other way can be another way to assess for facial weakness. In terms of drift or weakness of the arms, we ask that patients put their arms out in front of them at roughly a parallel to the floor, and what we would hope to see is no significant drift or dropping of part of the limb. If there is weakness of part of a limb, what we'll often see is a slow drift of part of the limb down to the body or down to the stretcher. If sometimes people are sleepy or unable to contribute, sometimes there can be droopiness of both sides at the same time, which is a little bit hard to interpret, but is not as indicative of a stroke as would be weakness of part of the body or one half of the body. And then last, in terms of evaluating speech and language, probably the easiest thing to do is ask people to repeat a simple phrase. One phrase that could be used is, "The sky is blue in Rochester," or any other number of phrases. People who have frank language abnormalities may not be able to repeat the phrase at all, which is often indicative of a stroke. Alternatively, people may be able to repeat the phrase but will have slurring of their words or dysarthria, which can also be indicative of a stroke.
Just to review, the Cincinnati Stroke Scale has 3 elements, the first being facial droop, by asking the patient to show their teeth or smile. The second element is arm drift, evaluated by asking the patient to close their eyes and extending their arms for 10 seconds. The third element is speech. This is evaluated by asking the patient to repeat a phrase, such as, "You can't teach an old dog new tricks," and scoring only the first attempt.
Well, any history that can be obtained is obviously very helpful to us. I think, far and away the most important thing that can be established about the history of the event is the time of onset. As of right now, we only have IV thrombolytic therapy, which can be given out to 3 hours as the only FDA-approved therapy for acute stroke. So establishing a time of onset, especially if it's within 3 hours, is extremely helpful to us. I think any other history that can be obtained, for example, of trauma, was the patient found on the floor, was there anything that might contraindicate the use of TPA, is obviously very helpful to us because we have to make a decision very rapidly, and the more history we can have, the better off our decision process will be. I think one thing that's also very helpful is to inform us of whether there's any family members available or whether any family members may be en route, because that's something that we often need. We often need extra history from the family in terms of past history or other time of onset questions that can help us decide whether TPA or any other therapies are indicated. I think the last thing that's helpful to ascertain if it's possible is medication use, because warfarin, for example, is one medication that if a patient is taking and has an INR that's higher than a certain level, we actually cannot give TPA. So if the medications that a patient's taking can be very quickly learned, that's very helpful for us. That can be tricky, and I think it's very important that people realize that time of symptom onset is the last time that someone was seen normal. I think the most common scenario we see is when people wake up with their symptoms, and they wake up at, for example, 7 o'clock in the morning, and people describe that as the time of symptom onset. Actually, symptom onset was then the last time before that the patient was seen normal. If they went to bed at 10 o'clock the night before and were neurologically normal at that point, and then have symptoms when they wake up at 7 o'clock the next morning, it's very important to realize that we have to use the last time seen normal, which would be 10 o'clock the night before, as the time of symptom onset. We don't at this point have a good way of determining whether those symptoms began right after that person went to sleep or right before that person woke up. So we have to assume the last time they were seen normal as the night before. So when EMS is seeing a suspected stroke patient, it's very important to make that distinction as to whether the person really had symptom onset at a certain point, or whether they woke up with their symptoms at that time point, because that is often a deciding factor when we decide to pursue either TPA or other options.
Key elements of the EMS history in stroke include when the patient's symptoms started, and this means the last time the patient was seen as normal, if there is any trauma involved, or if there are any family members en route to the hospital, and if the patient is on any medications, such as anticoagulants. After finishing this episode, you should have learned the components of a focused physical exam to evaluate stroke, be able to describe the physical findings associated with the stroke, and discuss what information is important to be relayed from the scene to the receiving facility.